Welcome to Mercy Medical Center's live webinar. Today's topic is chronic kidney disease. Joining us is Dr. Fadi Yacoub, Internist Associates of Iowa and Mercy Dialysis Medical Director. After his discussion, he will take questions from our audience. To submit your questions anytime during the discussion, go to the window in the upper right-hand corner of your screen and type in your question. If you don't see the screen, click on the orange box with the white arrow. Your questions will be confidential. Welcome to the webinar, Dr. Yacoub. I'm going to turn the mic over to you now so we can go ahead and get started.
Well, Lynn, thank you very much for inviting me today. Thank you guys for listening today, and please ask questions. If you don't, I'm going to have to ask myself, and it's not good usually to ask myself. I'll be talking today about chronic kidney disease, and as a nephrologist, obviously that's what I do day in and day out. People ask me what the kidney do, and they usually look at it as a garbage disposal. The kidney is not garbage disposal. It's actually a very, very nice refinery. And like any other refinery, it actually does produce gas to your car. However, it produces a lot of other things. And people certainly sometimes they get surprised when they hear that. So the kidney is simply not there just to make urine. It really does do a lot of different things I'll be touching on. One of the problems, though, is the kidney that people, do get surprised when we tell them they have some kidney issue. And they say, well, I feel fine. I go to the bathroom, I urinate, and really don't realize that you're not going to have any symptoms whatsoever until your kidney number drops below 90%. Now, for the audience who are not healthcare professionals, how would you know what your kidney function is? I can tell you a really simple way to do it. If you go to your metabolic panel, and they have a lot of different names, basic metabolic panel, chemical panel, and go to a little box called GFR. And usually you look for something called non-African American. And some labs actually do report it that way. And look at that number. That actually gives you an idea what the percentage of your kidney function is, roughly. It's not exact science here, but actually we give you a pretty good idea what's going on. So if you're GFR 15, you still have 15% of kidney function. If you're GFR 60, it's 60% of kidney function, and so on. So that would actually be good guidance to you about the kidney function you're dealing with. So in Iowa, actually in the Western society, really this is what you see in front of you, what causes kidney failure: diabetes and high blood pressure. I'm going to say it again: diabetes and high blood pressure. A little bit different from, let's say, Asia or Africa, but in States, in Europe, those two. Probably between high blood pressure and diabetes, we have about 90+% of our patients on dialysis, either diabetes or high blood pressure or both, are the main contributor to the kidney failure. And they're really bad. Unfortunately, both diabetes and high blood pressure are silent diseases. If your diabetes is uncontrolled, if your pressure is uncontrolled, for the most part, you really have no symptoms. And the same thing for kidney disease. And thus you could easily go on to end-stage kidney disease and needing dialysis, and you really have no idea that you actually even have a problem. A little bit different from the heart, a little different from the brain, when you actually have usually symptoms which kind of direct you to, there's something not quite right going on. And thus, as physicians and healthcare provider, we really need to screen for hypertension, for diabetes, and kidney disease, and tell the patient this is what's going on and this is what we can do to fix it for you. One thing I like my audience to know that we classify kidney disease to 5 stages. Stage 1, Stage 2, Stage 3, Stage 4, and Stage 5, where Stage 5 is the most serious part, some serious kidney disease. And it's not like cancer. And I had some people actually do tell me I have chronic kidney disease Stage 4, and they panic because they're thinking about cancer Stage 4. It's absolutely not the same thing. It's not stage 5. In the stage 5 is when you go on dialysis. So I don't like my patient to mix this classification with cancer classification. It's absolutely not the same. And honestly, I did not even know that some people do get mixed them together until my patient called me panicking with stage 4 kidney disease, and he thought he's going to die soon, and obviously that's absolutely not the case. So we do classify stage 1, 2, 3, 4, or 5. And for any of my patient, when we tell them you have stage 3 or 4, it's good to know what stage you are. However, you really need to ask the physician taking care of you, what my chances of going to a more advanced stage of kidney disease. If you're stage 3 and you'll never go to stage 5, it's really not a huge deal. But if you're stage 3 and you're going to be stage 5 in a year or two, obviously that's a big deal because you could be on dialysis within a year or two. So one of the questions you need to direct to us, really, as a kidney doctors, is what my chances are, what the odds are of going to stage 5 and into stage kidney disease and needing dialysis. And if if those odds are high, what timetable we're talking about and what can we do to change that. And this is a long list of kidney disease symptoms, and unfortunately, as you probably can see, they are very vague, very non-specific. And a lot of people come to me with kidney disease and tell me, well, my back doesn't hurt. I urinate. Unfortunately, back pain is not a sign of kidney disease, and urinating or not urinating, not a sign of kidney disease either. As you see, fatigue, loss of appetite, itching, nausea, vomiting, shortness of breath, swelling, all those are really very non-specific. Could happen in kidney disease or could happen in a lot of other diseases. And thus, it's critical for patients to screen themselves periodically to see if they actually do have kidney disease and how bad it is, because you really cannot count on the symptoms. When you start to have some of those symptoms from the kidney disease, you probably have advanced chronic kidney disease, probably stage 4 or 5. And at that time, it's really hard to do anything about it to slow it down. So how do you test for kidneys? There's a big slide right here. I'm going to make it simple. There are really 2 things we do to test for kidney disease. The first one is a creatinine, not creatine, creatinine. This is natural substance, come from the muscle, go to the kidney and filtered by the kidney. So we use it as a surrogate for kidney test. So that's probably by far is the best way to simply measure the kidney function. So creatinine. Urine analysis is critical, and I call urine analysis poor man kidney biopsy. By looking at the urine, actually I can probably get as much information as I can get from even kidney biopsy. And really, as a kidney physician, as a nephrologist kidney physician, I need 2 things when I see anybody, what their creatinine is and what their urine analysis is. Without really having any other information, I'll pretty much can tell them, where they are and where they're going to go and how long it's going to take to have kidney failure, if it will ever happen, what could be done for it. So those 2 tests, urine analysis and creatinine, are critical. Pretty much in my mind, everybody above age of 50 probably need to get it done at least once a year, especially if they have risk factor for kidney disease, namely diabetes and high blood pressure. And thus, you really have to detect the kidney disease by doing blood tests. And if you detect it late, if your creatinine 5 or GFR 8 or 9 and you came and see me, really there's very little I can do to change that at that time, for the most part. So when you detect it early, there's actually a lot of things we could do, either to prevent, and if you cannot prevent, slow the progression of kidney disease to end stage kidney disease and dialysis. And if I have to do really 2 things, I'm going to put 2 numbers up there for the audience. First one is your blood pressure, if you have kidney disease, has to be below 130/80. If you want to make it very simple, just remember 130 or below that. Now, people tell me, my morning sugar pressure is 120, my afternoon 145. Is that good or bad? you really look at the average. You just average 10 or 15 or 20 reading, and that average should be below 130. So I wouldn't worry too much if one value high or one value low. You just average them. If it's 125 or below, great. If it's 150, we got an issue we need to deal with. And for the diabetics, the A1C has to be below 7. And obviously diet, exercise, salt restriction, all that indirectly will certainly help your kidney. Up to 20 plus years ago, we really have no effective treatment for most kidney disease. If you have something called diabetic nephropathy, which is diabetes effect on the kidney, but for the most part, the kidney is really doomed. Within 3 to 5 years, people go on dialysis. And that's actually, that's the way it has been really from when the medicine started until 20 years ago. Then class of medication, actually the blood pressure medicine called ACE inhibitor and angiotensin II blocker. They first came as blood pressure medication, but we found, actually when you give it to somebody, protein in the urine dropped dramatically. Said, well, wait a minute, protein is a marker for kidney disease. If you drop protein, does that improve the kidney? Well, it turned to be that actually the case. And since we accumulated a lot of data to indicate ACE inhibitor as a class, and there's probably about 10 medication in that class, angiotensin II blocker, the same story, about 10 or 12 medication in that class, are highly effective in preventing progression of kidney disease. And that's actually, I'm going to emphasize it with very few exceptions, and I'm not going to even go into all patients with kidney disease by default should be receiving one of those agents. And if not, we need, as a physician or healthcare provider, need to ask myself, why not? And some people, creatinine is high, 3.5, they panic, they stop their ACE inhibitor because they read the insert as cause kidney failure. And I tell my patient that's really not true. The higher your creatinine is, the more benefit you get out of ACE inhibitor or angiotensin II blocker. Now, and I had cases when people ask me, well, I open the insert and I see kidney failure as a side effect of ACE inhibitor or angiotensin II blocker. And fortunately, that's true in very rare cases. And my job as physician tell my patient if that even applied to them or not. So what those cases are, if you're severely dehydrated, if you get very ill, nausea, vomiting, diarrhea, not able to eat, not able to drink, dizzy, lightheaded, please stop your ACE inhibitor, stop your angiotensin II blocker for a day or two. If you do that, risk of kidney failure is essentially non-existent. If you keep taking it, naturally the pressure is going to be low, the kidney is going to shut down. Temporary, but will shut down. So when you see kidney failure in the insert, you really have to be careful not to overread into it. That's very rare. That's not usually what we see day in and day out. The benefits, for the most part, in almost any patient, outweigh any potential risk here. And we have cases, instead of 3 to 5 years, what I mentioned, we've had cases when, we put them on ACE inhibitor since I started practicing in 98, and this is 2013. This is 15 years after, and they're doing well with stable kidney function, which is, again, unheard of 25 years ago before ACE inhibitor. As mentioned before, kidneys are not garbage disposal. They do a lot of things, and people don't realize that. I think a lot of people don't realize that the kidney is the main contributor to making red cells. And if you don't have kidney function, you're going to almost certainly be anemic. People also don't realize that the kidney is a main contributor to bone and bone movement and fragility of the bone. Without the kidney, the bones are absolutely in horrible shape, and you get diseases. Some of them are treatable, and some of them are not. And it affects clotting system. People tend to bleed when they have kidney disease, and actually a lot of other dysfunction. As a matter of fact, if your kidney doesn't work, pretty much really none of your other organs will work properly. And thus the kidney dysfunction is not a minor deal by any means, and it will affect you, and you will feel it when it's approaching end-stage kidney disease. And thus, when somebody had kidney failure, we really go with what the red cells is if it's abnormal, we need to fix it. How the bone look like, how the vitamin D, how the calcium, how the phosphate, we need to fix it. Well, the clotting system, is it normal, is it abnormal? And if usually abnormal, what can we do to make it better? We need to look at their medication, because the kidney is what clear most medication, and we need to adjust the dosing for them. So a lot of things we actually have to go through if somebody had kidney dysfunction. So the idea really is never ever get to dialysis or transplant. Well, unfortunately, that's sometimes not achievable goal. So what if the kidneys fail? Well, we do kidney replacement therapy, and we have multiple modalities we do. Peritoneal dialysis is one of them. In-center hemodialysis, home hemodialysis, and kidney transplantation. And this is honestly probably my favorite modality, which is peritoneal dialysis. Peritoneal dialysis is actually a very simple dialysis method, which could be done fairly easily and reasonably cheaply at home by almost anybody. And when we actually started dialysis in the 70s, a lot of our patients, most of our patients were doing peritoneal dialysis. And somehow we got away with doing that for quite a while. But the last 5-6 years, we realize it's underutilized, and really we need to go back to it, because frankly, in my experience, my patients in peritoneal dialysis generally feel better and do better than hemodialysis. It's a very simple modality to do. This is a machine right here called peritoneal dialysis machine. It's oversized VCR, and this is a fluid we use to do dialysis. And the patient had a little small tube in their stomach. They hook it up to this machine, they do the programming, they go to bed, and the machine sends fluid in and drain it out. Send fluid in and drain it out. And they wake up in the morning, and they unhook themselves, and they go on with their life, something you have to do every day. People really feel well on it, and they're pretty independent. This is why I like it that much. They don't depend on us doing stuff to them. They do it themselves. If the patient chose not to do peritoneal, or some people are not candidate for peritoneal dialysis for a lot of different reasons. Some of them are vision, too weak, they don't have enough help at home. They could go with hemodialysis. And hemodialysis really very simple in theory. The whole idea of hemodialysis is you take a blood from the patient, send it, right here, you take blood from the patient, send it to the machine. This is a filter. The filter purifies your blood and then send it back to you. And we do that through a big oversized vein we created surgically. And you could do this potentially at home, although technically a lot more complex and complicated than peritoneal dialysis. Or generally speaking, what most of our patients do is actually do it in the center. The people tell me, what is the outcome any different? The answer to that is no. Really, if you look at it several years down the road, the outcome peritoneal dialysis is very similar to outcome on hemodialysis. So if the outcome is the determining factor, I tell my patient, really choose either or, doesn't matter. You're going to do the same either way. Now, because they're so different modality, the patient choice and quality of life and what they like to do or not to do will decide actually if patient want to do hemo or peritoneal dialysis. If you prefer to do it at home, independent, you do peritoneal. If you said, I don't want to learn anything, I want to come to dialysis, let me get it done 4 hours, 3 times a week, and move on with my life, that's hemodialysis. Saying that, though, if somebody is a really big, muscular guy, it's somewhat hard to give him enough peritoneal dialysis, and those people probably do better with hemodialysis, as opposed actually to small, women and actually do better with peritoneal dialysis because they have small blood volume and they would not feel very well on hemodialysis. Kidney transplant, certainly, it's a nowadays no-brainer. If you have kidney failure and you're a candidate for kidney transplant, you get kidney transplant. That's absolutely a standard of care in nowadays. Very few contraindication for it. You need to be physiologically in decent shape, decent heart. Certainly, that's probably critical. You need to have decent social support, and you'll be fairly reliable taking your medication. That's really the only barrier not to get transplant. Age per se is not. So if you're somebody 75-year-old, otherwise physiologically in decent shape, should be able to get kidney. Now, why do we do that? Very simple. Survival after you get kidney transplant is very similar to average person who had no kidney failure, which is amazing if you think about it. Now, the survival on dialysis is by far much lower. So I have a patient 50-year-old is going to go on dialysis, and they're hesitant about kidney transplant. I tell them, well, how long do you want to live? If they told me I want to live normal life, I want to live a couple of decades talking to you, get kidney transplant. I cannot promise I'll be able to keep you healthy on dialysis for 20 years. It does happen, but certainly I would not bet on it. Generally speaking, the first 5 years on dialysis are reasonable. After 5 years, we start to see a lot of complication from long-term chronic dialysis, which is really hard to treat. So if somebody we have, in my mind, 5 years window, and we need to get people transplanted if they are candidate for transplant within that window. And contrary to popular belief, we do not take the old kidneys out. We leave them alone. We put the new kidney in the groin area, either on the right or the left. As a matter of fact, you can feel the new kidney if you push in your stomach in that area, as opposed to normal kidney, obviously, your own kidney, which you cannot feel. The surgery itself technically is really not that hard to do. We do, most of our patients go University of Iowa or regional centers. The results are absolutely superb. The rejection medication nowadays are absolutely awesome. There's a lot of work done on eventually find a way for the patient not to take any anti-rejection medication, but probably we're several years away from implementing that yet. So at this stage, most people will have to take at least 2, if not 3 rejection medications. And that's actually the end of my presentation, and I'm going to turn the microphone back to Lynn.
Well, thank you, Dr. Yacoub. To remind our listeners, your questions can be submitted from the box in the upper right-hand corner of your screen. Okay, our first question is really a review. Dr. Yacoub, who should be screened? Just people with high blood pressure and diabetes, or is it routine for everyone?
If you're very healthy and below 50, probably not needed routinely. But again, keep in mind that because chronic kidney disease is a very silent disease and diabetes very silent, and hypertension very silent. I like my patient to incorporate it into their physical exam. Certainly, if you're healthy, non-diabetic, and do not have blood pressure, it may not be a bad idea to check it between 1 to 3 years below age of 50. After age of 50, in my mind, you check it annually with your routine examination. So when you go for physical exam, pap smear, pelvic exam, rectal exam, prostate exam, it's certainly part of what I do routinely is check for the kidney test and glucose, blood sugar, and lipid, and urine analysis. Certainly, if you have high blood pressure or diabetes, that's not the case. Our recommendation will become a lot more closer monitoring of the above. So generally speaking, below age of 50, between 1 to 3 years. above the age of 50 probably annually. Again, just because they're totally asymptomatic, so you would not know you have kidney disease until it's too late if you don't routinely check for it.
You mentioned itching as a symptom of kidney disease. Can you explain why this is a problem?
Yeah, itching is actually one of probably the most devastating side effect of kidney, and when we have very few ways to treat it, and actually it's occasionally so bad it forces us to change the way we treat the kidney disease, and sometimes we actually do dialysis before we even want to. We don't really understand why people have itching in kidney disease. We have a lot of theories. One of them is because you're high phosphate, high calcium, or the combination of those two, or high parathyroid hormone contribute to that. It's probably true, but not in every case. Sometimes what we call uremic toxin, when all those bad byproducts the kidney used to filter, now moving around and cause and irritate the nerve ending and cause itching. Itching in kidney failure is actually it's so bad that people become absolutely focused on it. They prevent them from sleeping. Medication is highly ineffective against it, and really the best way to treat it, if that does happen and the medication does not help it, is either dialysis or transplantation, which generally speaking does make it better or eliminate it altogether.
Okay, Dr. Yacoub, you talked about the two types of dialysis, and this next question is just really saying, do you feel that one is more effective than the others? I know you talked about the advantages and disadvantages, but overall outcome, do you see any difference?
The outcome, really, if to look at it 3-4 years down the road, is essentially the same. There's some peculiar differences between those two. If you're making urine, you'll do better on peritoneal dialysis. If you're not making urine, you'll do better on hemodialysis. So actually, I do tell my patients there's absolutely nothing wrong with staying on peritoneal dialysis for 2-3 years and use and get the benefit advantage of doing peritoneal dialysis the first 2-3 years. After the first 2-3 years, when the kidney quit working altogether and don't make any urine at all, actually people do better on hemodialysis than they switch from peritoneal to hemodialysis. That's actually probably what a lot of people will do. But overall, though, if you look at it 5-6 years down the road with the current technology with both peritoneal and hemodialysis, really no significant difference between those two, and the determining factor is the patient. If patient want to do it at home, do peritoneal. If somebody want to do it in the center, they do hemodialysis, more so than the outcome.
I have a question here related to the kidney transplant. What is the typical weight once you get on the list?
There's two ways to get kidney transplant. Obviously, either a living donor, and that could be a family member or a friend or a neighbor or somebody you never met in your life, as long as they're willing to give you a kidney. And the waiting time on that is actually pretty brief. We're talking probably several months until we get the typical testing prior to transplant. If that's unfortunately, which is not uncommon, not an option for some people, they have to wait for cadaver. When somebody passed from accident or stroke or something of that sort, and his family were generous enough to donate their kidney, we have to wait for that. And average time, generally speaking, in Midwest area, between 3 to 4 years. That's actually pretty good. If you go to the East or West Coast, average time between 5 to 7 years. So we have actually a lot better waiting time in Midwest area. So average between 3 to 4. And some people get lucky because of matching issue and so on, and they get it faster, 2+ years. Some people get really unlucky because they have a lot of antibodies, which could prevent them from matching with a lot of other people, and they could wait 4+ years. But generally, if you're a really good candidate, you probably will get your kidney below 4 years mark.
Okay, a question about dialysis. Dr. Yacoub, what is the cost and does insurance cover it?
Yeah, dialysis is actually a very complex procedure in spite of what appear to be simple, fluid exchanges. And it's actually very costly. To do dialysis alone, hemo or peritoneal, it costs Medicare probably between $60,000 to $90,000 a year, every single year. So by any means, not a cheap modality to treat people. And on national level, it costs us about $30 billion to treat dialysis. Really out of reach for most people. Thankfully, if you have end-stage kidney disease, you automatically, eventually, for the most part, automatically qualify for Medicare coverage to do that. And you Medicare cover about 80% of the cost. The rest, 20%, either supplemental insurance or it's a patient responsibility. So usually we recommend pretty much all our patients to get supplemental insurance because 20% is still, we're talking significant amount of money for a lot of people. So it's not cheap, and that's actually one of the reasons we focus on preventing kidney disease from progressing to dialysis, because it takes a significant toll on the nation financially. And to kind of give you an idea, when dialysis started in late 60s, early 70s, you really pretty much you have to go in front of committee to decide if you can do dialysis or not. And literally they said, no, we're sorry, you're too old. You can't get dialysis. In 1972, though, the Congress did pass a law for everybody on dialysis to be covered by Medicare. And at that time, they estimated the growth of dialysis patients at a significantly lower rate than what we have right now. If you apply that equation and look at it right now, you would think we have about 30 or 40,000 patients on dialysis by now. We have about 600,000. So they grossly underestimated the risk. So the initial cost certainly were grossly underappreciated by the Congress. So it's very expensive, and there's absolutely no end in sight. It will keep going up because we have a lot of diabetes. We have a lot of high blood pressure. We're getting older and we're getting bigger. And thus, this is unfortunately, one of the diseases we don't really have a lot of good handle on so far. If you look at the cardiac disease, it seemed to have stabilized at the last decade or so. If you look at most cancers, it seemed to have stabilized. Kidney disease has not. And I'm not certain when it will stabilize. We're certainly hoping with a better diabetes control, high blood pressure control, and maintaining good weights and so on, that those numbers will stabilize in the next 5, 10, 15 years. But at this stage, it's not entirely clear when. And if we keep at the current rate, in 5, 10 years down the road, it will be million and a half, and you do the math. It's almost 100,000 a year, and it's immense amount of money as a nation we have to spend on. So the human cost is significant, human suffering significant, and certainly financial impact is significant. So, and if you do get dialysis, if you do go on dialysis, we immediately try to switch over to transplant mode. A, people feel better, live longer, and B, it's financially a lot more feasible and affordable. The transplant is one-time cost for the most part. You do need to take rejection medication, but nowadays they're actually reasonably affordable enough that most people can afford them.
Okay, well, Dr. Yacoub, you've been talking about the cost. What happens if a person chooses not to do anything for kidney disease? Can you tell us a little bit what they might expect?
Yeah, that's certainly a valid option for some people, and some of my patients do choose that option. Dialysis is not for everybody, and if you're 85, 90 years old and have kidney failure, your dialysis is imminent within next few months, I tell my patient, you have to think about it. Is that something you want to go through? And some people choose not to. That's certainly a very valid option, and I tell my patient it's not committing suicide by not doing dialysis. As a matter of fact, frankly, it's what probably I would do if I'm 90-year-old and have kidney failure. So what do you expect? I tell my patient you'll probably feel okay, not great, okay, until your GFR, the percentage of kidney function, drop below 8. Below 8, you see significant complication of dyspnea, shortness of breath, nausea, lack of appetite, not feeling well, poor general malaise, and so on. For the most part, those are manageable by certain medication, especially the shortness of breath. Until the GFR, the percentage of the kidney function drop below 3 to 4%, at that time it's incompatible with life. And death usually occurs within weeks or months. It's impossible really to predict it. I have seen people with GFR of 4 and 3, and they're still alive and doing okay, which is fine as long as they're asymptomatic or minimally symptomatic. However, if your kidney function deteriorated to a point when it become really hard to manage the complications, we do ask people to consider hospice, and that's certainly they work with them in the last days or weeks of their life to treat their symptoms.
Thank you, Dr. Yacoub. A tape of this program will be available at www.mercycare.org/live, and this should be posted within the next day or two. You can always check this website for information about future webinars and listen to past webinars. Our next webinar topic is Adverse Childhood Experiences with Alyssa Drury. She's a counselor at Mercy Family Counseling. It will be held Thursday, April 11th at noon to 1, and she will take your questions live after her discussion. Another event I want to point out to our listeners is the Living Well with Chronic Kidney Disease. This will be Tuesday, April 23rd from 9 until noon in Mercy's Halligan Education Center. This session will really expand on today's webinar topic. It's going to include topics such as kidney basics, important blood tests, nutrition, kidney transplant, adjustments to kidney disease, and kidney dialysis. To register, call 319, the number on your screen, 221-8878. Now, if you're interested in future Mercy webinars or other educational events, you can sign up for Mercy's e-newsletter. And this is mercycare.org/e-news. I believe we have covered all questions submitted to us, but if you have additional questions or concerns, Dr. Yacoub can be reached at 319-398-6423. Thank you for joining us today.